everyone. Assalamu alaikum. And my name is Muhammad. I'm a lecturer at the University of Amud and University of Hargeisa. Today I'll talk about introduction to scrotal ultrasound. And ultrasound is the modality of choice for evaluating the scrotum. And despite the more sophisticated imaging modalities, ultrasound remains the first line and frequently the only imaging modality used in the assessment of scrotal abnormalities. I will discuss the anatomy of the scrotum, scanning techniques, and common pathology. Anatomy of the scrotum. The scrotum is divided into two longitudinal chambers by fibrous scrotal septum. This is the fibrous scrotal septum. The wall of the scrotum is made up of many layers. Here's the skin. And the next is superficial fascia. It is made up of many layers. The next is superficial fascia. It is continuous with the fatty and membranous layer of the fascia of the anterior abdominal wall. Then next in this red color, this is the spermatic fascia, and it is derived from three layers of the anterior abdominal wall, the external spermatic fascia, which is outer, and cremasteric fascia, and internal spermatic fascia. Beneath the internal spermatic fascia is the parietal layer of the tunica vaginalis. This is the parietal layer of the tunica vaginalis, and this is the visceral layer of the tunica vaginalis, and between them, there is potential space between the visceral and the parietal layer of the tunica vaginalis. Usually it contains 2 to 3 milliliters of fluid, normal fluid. Testes are ovoid gland covered by tunica allogenia. And internally, there's a projection to form septa. There's a septation that is internally projecting into the outer side that divides the testis into small lobules. These septa converge posteriorly to form the area of the mediastinum. The lobules contains what is called nephros tubules. Nephros tubules converge posteriorly to form a network. This network of channels is called rete testis. Rete testis is located within the fibrous of the mediastinum in the testis. There is 10 to 15 efferent dactyls emerge from the rete test and convey seminal fluid from the testis into the head of the epididymis. The epididymis is this curved structure, consists of head, body, and tail, measures 6 to 7 centimeters in length, and laying posteriorly to the testis. Here, the head contains 10 to 15 efferent dactyls that's coming from the rete testis. These ducts join together to form single convoluted duct. The ductus epididymis has very tortuous route from the head to the tail of the epididymis, where it tends to exit into the spermatic cord from the epididymal head. So it's starting from the epididymal head and it's going to the spermatic cord. The duct is called vasa deferens, and of the ductus, it emerges from the tail of the epididymis. This vasa deferens exits the scrotum as part of the spermatic cord. The vascular supply of the testis. The arterial supply to the scrotal sac contains contents arise from the three sources: the testicular artery, cremasteric artery, and artery to the dectus deferens. The testicular artery, this is usually the cremasteric artery and the testicular artery. The testicular artery is direct branch of the abdominal aorta that enters into the scrotum through the spermatic cord. And the cremasteric artery is a branch of inferior epigastric artery supplying the scrotal wall and the scrotal sac and conferring the spermatic cord. And the artery to the dectus deferens arise from the superior visceral artery. These arteries all supplies the scrotal sac and the content of the scrotal sac, which is mainly the testis and epididymis. Testicular veins pass also through the mediastinum as they exist the testes. The network of veins posterior to the testis is called pampiniform plexus. These are what's called the pampiniform plexus. Each plexus of veins eventually form two testicular veins, which form single testicular vein. The right testicular vein drains directly into the inferior vena cava below the level of the right renal vein, whereas the left testicular vein drains into the left renal vein. The plexus of vein plus three arteries of the testicular cremasteric differential arteries, in addition to lymphatics, nerves, and vas deferens. All these three are loosely held together in connective tissue in the spermatic cord. The spermatic cord runs from deep inguinal ring into the scrotum. It's starting from the deep inguinal ring here and going into the scrotum. So it contains here arteries, veins, and lymphatics. Before scanning the patient, it is important to determine the clinical findings. Why the patient was referred? Is it due to the palpable mass? So you have to know why the patient is referred. Is it due to the palpable mass, scrotal pain, swollen, or other reason? Ask the patient to describe symptoms, including history, location, duration of pain. Also, ask the patient if he can feel a mass. Ask where is the mass? And when you locate the area of the mass, put the probe on it. Place the probe exactly over the location of the examined site. Again, ask the patient if he had a trauma. Ask him when what happened. This information is necessary not only for guiding the examination, but also for interpretation. Scanning techniques. Patient is in supine. The penis is held, as it is here, by the patient against the abdominal wall. The patient is asked to place his legs close together, or sometimes you can use a towel, and this to provide a support for the scrotum. And a lot of gel is applied to ensure adequate probe contact and to remove air between the probe and skin surface. Use high frequency probe of between 7 to 14 megahertz linear array transducer. Color and spectral Doppler is very helpful, as we will see later. The entire scrotal sac should be examined in order to include both transverse and longitudinal image or longitudinal planes. Then the sonographic appearance, the scrotal wall, we will start from the scrotal wall. The scrotal wall appears as 3 layers. These tunica vaginals, and sorry, this is the tunica brietals, and this tunica vaginalis. Next is tunica vaginalis, the visceral layer, and the last one is tunica albuginea. What's important here in the skin of the scrotum, scrotal sac, is to see if there is thickness or not, if it is swollen or not. Then the normal testes are homogeneous in echo texture with uniformly distributed medial level echoes. Size and echogenicity of the two testes should be identical. When you are scanning testes, think of these questions. Is the parenchyma homogeneous or heterogeneous? Is there a mass? Is there a mass? If yes, is it cystic or solid? Is it intratesticular or extratesticular? This is sagittal view of the testis, showing medial and lateral portions, medial and lateral portions. Two measurements are obtained in this view, longitudinal and depth. Then transverse view, and this to show superior, mid, and inferior portion of the testes. The width of the test is measured in this transverse view. In adults, testis measures approximately 3 to 5 centimeters in length and 2 to 3 centimeters in both depth and width. We are going more into the anatomy, sonographic appearance. This is the mediastinum. Appears as highly echogenic linear structure that extends craniocaudally within the test and parallel to the epididymis. And it is draining the seminiferous tubules of the testis into the rete testis. This is the rete test, appears as low reflective area or hypoechoic area at the hilum of the testis. It has a finger-like projection into the parenchyma. And this is the intratesticular band, also known as a vascular cleft. It is a hypoechoic band in the middle or in the mid-third of the testis, nearly perpendicular to the mediastinum on sagittal scan. This band is visualized in about 10% of normal testes, and it measures up to 3 millimeters in diameter and 30 millimeters in length. And the band is caused by a prominent artery. This is the prominent artery and vein called mediastinal vessels. This vein and artery that are adjacent to each other is called transmediastinal vessels. It can be easily seen with color Doppler. And this is the appendix, usually seen when there is fluid. Fluid can help you to see like this appearance, which is appendix. It is normal and it is kind of different, can be seen in different patients, and it's normal. A small round prominence extending from upper pole of the testis. It is only 1 to 3 millimeters long and isoechoic with the testis. It should appear like the testis because it has the tissue appearance, the tissue content of the testis. And here is the epididymis. It is isoechoic with the testis, and it is echo texture might be coarser and slightly coarser than the testis. The head normally measures 10 to 12 millimeters or 1 to 2 centimeters and lays lateral to the superior ball of the testis. The body is here, extends inferiorly from the head and is found posterior lateral to the testis. The normal body measure is less than 4 millimeters in diameter. The body is hypoechoic when we compare with the adjacent tests, and often defined only by its bright anterior and posterior wall, like it is here. There's a bright wall here and bright wall here, which defines that this here is the body of the epididymis. The tail and appendix of the epididymis are usually and routinely not seen unless there is free fluid. The fluid can only show you. Then let us go to the pathology. And this is the list of pathology we'll discuss in this session. We will begin with the congenital and undescended testis. Undescended testis is also known as a cryptorchidism. It is the failure of testis to migrate from the abdominal cavity through the inguinal canal into the scrotum. Approximately 80% of undescended testes are located within the inguinal canal, and only 10 to 25% of cases are bilateral. The surgical freeing of undescended testes and implanting into the scrotum is known as orchiopexy. Orchiopexy means surgical freeing of undescended testes and implanting into the scrotum. And this will not reduce the risk of malignancy, but at least it will help the lump to be detected earlier and treat earlier before it is testes. Also, testicular torsion is more common with undescended testes. This is an example of undescended test. In the left side, small, hypoechoic mass-like, but it is giving you the appearance of the test with testicular texture. It is seen next to the internal inguinal ring. Another example of inguinal undescended test for a 3-year-old boy with a single palpable testis. Here, the test is elongated, relatively decreased. When we compare with this, it is decreased in echogenicity. It is hypoechoic. Epididymo-orchitis. Epididymo-orchitis is infection of epididymis and testes, and it is the most common cause of acute scrotal pain in adults. It predominantly affects sexually active male, less than 40 years, and the older patient with urological disease, and in cases of prepubertal boy with the association of, if there is also associated urogenital anomalies. Sonographically, epididymo-orchitis will appear as hypoechoic gland. Sometimes in the epididymis, it will appear as hypoechoic gland. Sometimes there might be reactive hydrocele or hematocele, or sometimes Pyocele with septation and scrotal wall thickening. On color Doppler, there is increased flow, and this will now as a mark of hyperemia. This will confirm the diagnosis of inflammation. If the infection is spread into the testis, it will cause testis to appear enlarged in size or swollen. And it will appear also because of the content of the edematous tissue, because of the content are more fluid, it will appear hypoechoic compared with the surrounding tissue. And this will result in heterogeneous appearance of testis. On color Doppler, there is increase of blood flow or hyperemia. This is an example of epididymis. This is the epididymis. Here it is swollen or enlarged in size. And here there is complex fluid, free fluid, with many septations that are thick. Even the fluid here is not clear fluid. There is low echogenicity of fluid, which might give you there is a bus or not serous fluid. The color Doppler here show hyperemic flow. increased blood flow. This is another example of orchitis. It is focal, not diffuse, because this is the area of hypoechoic and the area of the normal echogenicity of the texture of the testis. And it might look like here, if you see, it look like focal nodule or focal lesion, like a mass or infection. But what differentiate between the two are the clinical history. This is an example of diffuse. Here it was focal, and this is diffuse. Diffuse orchitis, diffuse inflammation through all the testis. It is swollen, and the wall of the scrotum is thickened. And here parenchyma shows patchy areas of low echogenicity. And here there is marked increase in color Doppler or Doppler signal. And this will show you hyperemic flow. This appearance that might persist for several months following treatment, sometimes difficult to exclude a neoplasm or malignant lesion. So it's important that diffuse and focal changes of the testis, like if it is here, this is in suspected orchitis, to have follow-up scan to ensure complete resolution and to rule out if there is neoplasm or it was only inflammation. Scrotal trauma. The most important goal of the ultrasound in testicle is to determine if there is, because rupture of the testis is surgical emergency that require immediate diagnosis. In ultrasound, we see discontinuity of the tunic albuginea and regular heterogeneous testicular margins, and hematocele. Hematoma might be seen displacing the testis initially as high reflective area, but subsequently as low reflective complex cyst structures. And in this case, the color Doppler might be helpful in differentiating hematoma from other masses by identifying it as area of blood flow. This is an example of testicular rupture. Here we can see interruption of the tunic albuginea and extruding of the isoechoic lesion representing the test or testicular contents. The surrounding hypoechoic lesion is of hematocele. Here above, here we can see of hematocele, and inside subcapsular, here below the capsule, we can see the lesion here is subcapsular hematoma. No flow signal is seen in the area of extruding isoechoic lesion. And in this image, the surgery confirms testicular rupture with extruders of testicular content covered by area of hematoma. Another example of testicular rupture in this, this area of loss of tunic albuginea and extruding of testicular content outside. And it is less echogenic, or sometimes it's hypoechoic. And here there is hematocele blood collection out of the area of the capsule. And the image here confirms what ultrasound is showing you in this picture. Spermatic cord torsion. It is when a spermatic cord is twisted and the vascular supply is cut off. Usually it is due to the abnormal mobility of the testis within the scrotum. And the main cause is what is called Bell Calabar deformity. Bell Calabar deformity. So what's Bell Calabar deformity? The main cause here is the main Calabar deformity. Normally the testis and epididymis are surrounded by tunica vaginalis, except the bare area. There's the bare area where they are attached to the scrotal wall. The bell calabra anomaly occurs when the tunica vaginalis is completely surrounded by the testis and epididymis, the distal spermatic cord. All of it here is enclosed by the tunica albuginea. This will allow them to move and rotate freely within the scrotum. This movement is likely that of the calabra inside the bell. Look, in this image, what we see, there is hydrocele within the tunica vaginalis. There is no fluid here in the posterior testis because of absence of tunica vaginalis in this area. And what about this image? In this case, the testis is completely surrounded by hydrocele, hanging and the extremity of the spermatic cord. And this patient is at high risk for spermatic torsion or spermatic cord torsion. Spermatic cord torsion is an emergency, and it is important to obtain diagnostic image as quickly as possible because the salvage rate depends on the time of the surgery. If surgery is done within 5 to 6 hours, first 5 to 6 hours of the onset of the pain, 80 to 100% of the testis can be saved. And between 6 to 12 hours, the salvage rate is 70%. And only 20%, look here, only 20% will be saved if surgery is done after 12 hours. Clinically, torsion might be or might present like epididyma or Cysts. It will show you pain, swelling of the scrotum. Ultrasound, especially color Doppler, is very important and vital here to differentiate between the two. Ultrasound finding, depending on the time passed through, since the time of the torsion in early stages, scrotal content may appear normal, 1 hour or 2 hours. After 6 hours, you will see swollen and hypoechoic testis. After 24 hours, testis become heterogeneous as a result of hemorrhage, infection, necrosis, and vascular congestion. The most important feature is the absence of colored Doppler flow. There is no blood flow in the symptomatic testis when you compare with the asymptomatic testis. This is an example of early testicular torsion. And in the left torsion, this is a longitudinal image, sagittal plane, and this transverse plane for the left testis. It shows you it is swollen and mildly hypoechoic, and there is hydrocele or fluid around it. And this is another example of testicular torsion, but this is after 12 hours, already it's damaged. It is heterogeneous, as you see in echo texture, and edematous. Edematous, you will see thick, the thick serosa, and the content is echo heterogeneous, areas of hyper, areas of hypo, and the surrounding fluid, which is edematous fluid. And this is twisted spermatic cord. It is rarely twisted, but with the help of the fluid around it, twisted spermatic is enlarged, and at the area of the superior posterior to the epididymal head, and you will see an echoic structure representing veins, and it is resembling what is as a whirlpool sign. Whirlpool sign. It will give you whirlpool sign. This sign was detected by MRI image. And here is a comparison between normal left side, left testis, with the torsion right testis. It is better usually to compare between the two testes when you suspect there is a torsion. And here you can see there is blood flow. And here there is no blood flow with the use of color Doppler. But make sure here that same setting of the color Doppler, the same setting of the color Doppler are used in both tests. This is another example of normal test when you compare with the torsion test. Here there is fluid, and here there is blood flow, sorry. Here there is blood flow, here there is no blood flow. So again, it is important to compare the two tests and use the color Doppler in both and make sure that you are using the same color setting in both. And hematocele. This develops at the potential space between the visceral and parietal layer of the tunica vaginalis. Normally, there is a small amount of fluid in this space. This space, there is usually normal, this physiologic. And hydrocele contains serous fluid. It's the most common cause of pain. Hydrocele might be associated with trauma, torsion, infection, sometimes infection, tumors, or sometimes even it can be idiopathic. Fluid collection surrounding the testis except posteriorly when the tunica vaginalis, where the tunica vaginalis is absent. And here is hematocele, and hematocele and Pyocele less common than sometimes we'll give you or will show you same appearance. Hematocele can be caused by trauma, surgery, diabetes, neoplasm, or torsion. And the Pyocele can result from rupture of abscess into the existing hydrocele or directly into Pyocele contains internal aqueous. Pyocele contains internal aqueous are associated with internal septation, as it is here, loculation. So to differentiate between Pyocele and hematocele, you need to have a clinical history and to ask the patient whether he had a trauma or not. But on ultrasound, it will show you both of them, heterogeneous, low level echogenicity, and depends on the time of the trauma, if there is hematocele. And both of them, they can show you septation, thin or thick septation. And both of them can show you floating area, floating testis, except the area where there is no tunica vaginalis. The varicocele. Varicocele is an abnormal dilatation of the veins of the bambiniform plexus located within the spermatic cord. The varicocele is present in up to 15% of asymptomatic adult patients, and 40% of it are bilateral, and 40% of infertile patients might show you varicocele. 78% of it is in the left side, and only 6% is in the right side, and 15% are bilateral. And this refers to the angle of which the left testicular vein enters to the left renal vein. So this is this sketch. This dilatation of the veins arises more often on the left side, and many authors refer this to the angle. Left testicular vein enters into the left renal vein, which is almost perpendicular. And this might cause the valves to be incompetent and allow retrograde flow, resulting in dilatation of the bambiniform plexus of the veins. The normal vein measures 0.5 to 1.5 millimeters, and if it is greater than 2 millimeters, we can consider it abnormal or varicocele. Look this, on ultrasound, the varicocele shows multiple tortuous tubular structure of varying size. It is best seen superior and lateral to the testis. Here you can see sometimes varicocele is becoming more prominent. This is when patient performing what's called the Valsalva maneuver. Look here, this is another example of varicocele. You can see when we are doing Valsalva maneuver, it will show you more prominent or more clear. Scrotal masses, ultrasound is very or extremely sensitive to detect testicular mass. It is the primary role is to determine whether mass is intratesticular or extratesticular, cystic or solid, because intratesticular solid mass must be considered malignant until otherwise proven. Benign testicular masses, intratesticular cysts or cystis are quite common in men older than 40 years. It is an incidental finding on ultrasound found in 8 to 10%, and it is usually located near the mediastinum. Cyst might be single or multiple, and it could be variable in size. This is a cyst. On ultrasound, it appears like any other cyst. It should be oval or round in shape, and the content is hypoanechoic fluid with posterior enhancement. And this is a cyst located within the dense tissue of the that's closely adherent to the tunica albuginea. These cysts are usually palpable by the patient as a thin nodule on the surface of the testis. And this cyst is at the head of the epididymis. So all the cysts are showing you like it is either round or oval in shape with a posterior enhancement and anechoic content. Tubular ectasia or Rita testis, it is dilatation of the testicular mediastinal tubules. The Rita testis here is located at the hilum of the testis, where the mediastinum of the testis rises. Cystis ectasia or Rita testis is uncommon. It is benign condition, results from partial or complete obstruction of efferent ducts, often by inflammation or trauma. It is usually associated with the presence of spermatocele or epididymal or testicular cyst. So here on ultrasound, normal Rita testis might not be seen, and tubular ectasia appears, it is early here, but not usually appears in the normal. Tubular ectasia appears as prominent hypoechoic channels that's near or to the echogenic mediastinum. This might resemble intratesticular varicocele. It will appear like intertesticular varicocele, but to differentiate between the Rita test dilatation and intertesticular varicocele, you have to use color Doppler. The color Doppler will differentiate between the two. And this is panoramic view of the right and left tests, and this shows dilatation of the Rita test on the left side. Scrotal hernia, and the scrotal hernia might contain a small bowel, colon, and or omentum. Usually, the clinical examination is enough, but ultrasound might be useful in difficult case. On ultrasound, it will show you the hernia contains bowel or omentum, and this giving rise to you will see peristalsis inside the fluid, or sometimes you can see there is a reflective echogenic omental fat. In this clip, you see here the intestine with the peristalsis, and there is a fluid. Look again, this is the intestine, with peristalsis. Here is peristalsis in the intestine and surrounded by a fluid. You see like this peristalsis in the area of the scrotum, then you recognize this is scrotal hernia. Malignant testicular mass, testicular carcinoma. This accounts only for 1% of all cancers in men. Most common malignancy in men at the age of 15 to 35 years. Fortunately, it is curable and survival rate is about 95%. The risk factors are previous testicular tumor, family history, cryptorchidism, and infertility. Most patients present with painless testicular lump or testicular enlargement. Seminoma is the most common cancer of the testis in adults and the most common tumor associated with cryptorchidism. Seminomas are radiosensitive and respond well to the radiotherapy in more than 90% of patients. And typical sonographic appearance are hypoechoic, homogeneous, solid mass. It has well-defined round or oval shape and can be multifocal within the testis. Also, it might present in atypical appearance as heterogeneous, lobulated, multinodular areas, and might be difficult sometimes to differentiate from testicular infection, torsion, or abscess. And in this case, it is important the clinical history can help you. This is a small seminoma with characteristics of the typical characteristics, appearance, homogeneous, and it is hypoechoic and well-defined in some areas, and most commonly, most areas it is well-defined. And here the test, this is very large seminoma that is mostly replaced by replacing the testis or the parenchyma of the testis. And it is homogeneous echo pattern. And here you can see very small space or remnant of the testis. Other areas are replaced by the mass or by the seminoma. On color Doppler, here you will see the flow that is showing the feeding vessels. The non-seminoma tumors is also an active group of various cell types affected by the younger patient and are more aggressive. Their appearance on ultrasound reflects this diverse nature of the histology, but commonly it shows heterogeneous with hypoechoic area, like it is corresponding to the hemorrhage. Margins are irregular or poorly defined. This mixed germ cell tumor contains more than one germ cell. The most common combination is a teratoma and embryonal cell carcinoma. Heterogeneous, look here, it is heterogeneous. Slightly more echogenic than the surrounding structure or the normal areas of the testis. And it's not clearly defined like a seminoma. In some areas, it is, you can't say the borders of the mass because it's invading the adjacent structures. And this is pure embryonal cell carcinoma. It is the most aggressive primary germ cell tumor. It is heterogeneous and well-defined in these areas and ill-defined in these areas where it is invading the tunica albuginea and adjacent structures. And this is an example of teratoma, large teratoma occupying large area of the testis. It is heterogeneous. It is showing area of cystic degeneration and areas of calcifications with ill-defined margins. Testicular microlithiase, it is described as the appearance of multiple tiny bright foci measuring 1 to 2 millimeters in diameter, which might show unilateral or bilateral. Acoustic shadowing is not seen usually because it is a small size of calcification. Studies shows that between 1.3 to 6.2% of these microlithiases are seen in people with infertility, and 6.7% of microlithiases are seen in Cryptorchidism. And there are tumors usually associated in 44% of the microlithiases. This longitudinal and this transverse image of the testis, of the left testis. Here you can see multiple very small tiny calcifications that is spread through all the testis. Through all the testis evenly and distributed equally. And there is no posterior shadowing in these small or tiny calcifications because of it is a small size. And finally, let us summarize what we have discussed. We reviewed the anatomy of the scrotum. It is normal sonographic appearance. We discussed common scrotal pathology, including congenital anomalies, infection, trauma, scrotal mass. And finally, I'm saying thank you for your attention. Thank you very much.